Welcome everyone to the Apothecary Tales, the basics of pharmacology. Today we're going to talk about a respiratory condition that is chronic obstructive pulmonary disease. So in this video we're going to talk about the basic introduction regarding the COPD. So this chronic obstructive pulmonary disease is a disease state characterized by airflow limitation that is not fully reversible, and the airflow limitation is usually both progressive and accompanied with airway hyperreactivity and is associated with an abnormal inflammatory response of the lungs to the noxious particles or gases. And there are two major forms of the COPD which usually or more frequently are coexisting in nature, that is the chronic bronchitis and emphysema. Chronic bronchitis is usually characterized by the excessive mucus production of the tracheobronchial tree. So what happens is that when the edema or the bronchial inflammation occurs, this can lead to the excessive mucus production of the tracheobronchial tree, and this will lead to the airway obstruction. And in most severe cases, what happens is that the patient will cough about 30 ml of the sputum for or about in 24 hours for at least 3 months of 2 consecutive years, and other causes of the chronic cough are usually excluded. And the next one is emphysema. So what happens in emphysema? First, we'll just talk about the simple anatomy of the lungs, that it consists of the trachea, then it gets divided into right and left primary bronchus at the carni, and then into the primary bronchus, then segmental bronchus, and finally the terminal bronchus, which basically has got alveoli at its distal part. So what happens in emphysema is that enlargement of the alveoli present distal to the terminal bronchioles will lead to this emphysema, and at the same time there will be districted changes in the alveolar wall. The lack of uniformity in the air space enlargement will further cause the loss of alveolar surface area. And the collapse of these small airways results in airflow limitation that is independent of exertion. Now we're talking about the basic causes or risk factors that can contribute to the development of COPD. So first primary causal factor, which is usually seen in about 90% of COPD patients, is the smoking. The smoking is directly linked to the progressive decline of the lung function as demonstrated by the forced expiratory volume in 1 second. So what is the main mechanism in smoking is that smoking will further lead to the pulmonary hyperreactivity, and this will further lead to the pulmonary airway obstruction. So it is very important that smoking cessation and or continued avoidance should be recommended regardless of stage or severity of COPD and age of the patient. Next important factor is the AAT deficiency. So what is the function of AAT? That is alpha-1 antitrypsin. So this is a serine protease inhibitor, that is a protein that is produced mostly in the liver. And the primary function is to inhibit the neutrophil elastase. Now what is the role of this neutrophil elastase? It is responsible for digesting the damaged aged cells as well as the bacteria in the lung, and thereby promoting the healing. So what happens in AAT deficiency that is mainly attributed to the smoking is that the inhibition of the neutrophil elastase occurs and the activity of the neutrophil elastase does not happen. Next factor contributing to the development of COPD is the exposure to the irritants such as the sulfur dioxide, as in the polluted air, the noxious gases, and organic or inorganic dust or combustible fuels in the home. Next factor is the history of respiratory infections or bronchial hyperreactivity. Then is the social, economic, and hereditary factors. So these are the main factors responsible for causing the COPD. Next, we are moving on to the pathophysiology of chronic bronchitis and emphysema. So the main two features of the COPD. So what usually happens in chronic bronchitis? So the respiratory tissue inflammation occurs in the chronic bronchitis. As a result, it leads to the vasodilation, congestion, mucosal edema, goblet cell hypertrophy. So what is this goblet cell? It is mainly responsible for secreting the mucus to protect the mucous membrane. So all of these events will further trigger the goblet cells to produce the excessive amounts of the mucus. Now the changes in tissue that can be observed is that there is increased smooth muscle, cartilage atrophy, infiltration of neutrophils and other cells, and the impairment of cilia. So what is the role of the cilia? It is mainly to keep the airways clear of mucus and dirt. Now, and these factors will further lead to the airways to become blocked by thick, tenacious mucus secretions which trigger a productive cough. Normally, sterile airways can become colonized with Streptococcus pneumoniae, Haemophilus influenza, Moraxella catarrhalis, Staphylococcus aureus, and Pseudomonas aeruginosa species. And recurrent lung infections, both can be viral as well as bacterial, reduce the ciliary and phagocytic activity, increase the mucus accumulation, weaken the body's defenses, and further destroy the small bronchioles. As these factors causes the airway degeneration, overall gas exchange is impaired, causing the exertional dyspnea. So what is this exertional dyspnea? That is shortness of breath during the exercise. So this gas exchange impairment leads to the VQ imbalance. So what is this VQ ratio? It is the amount of air reaching the alveoli divided by the amount of blood flow in the capillaries in your lungs. So this VQ imbalance leads to hypoxemia, which in turn leads to the hypercapnia, that is the increased arterial carbon dioxide tension or the increased partial pressure of carbon dioxide. And if this condition sustains for a very longer time, this causes the desensitization of the brain's respiratory control center and central chemoreceptors. As a result, the compensatory action to correct the hypoxemia and hypercapnia, that is the respiratory rate or the depth increase, does not occur. Instead, the hypoxemia serves as a stimulus for breathing, and use of narcotics or benzodiazepines, that is the respiratory depressing kind of action they have, so thereby especially in combination, should be done cautiously in these patients to avoid the respiratory failure. Next, we're talking about the pathophysiology of emphysema. So the anatomical changes that we usually see is the loss of tissue elasticity. Inflammation and excessive mucus secretion, as from the long-standing chronic bronchitis, causes air trapping in the alveoli. This contributes to the breakdown of the bronchioles, alveolar walls, and connective tissue. As the clusters of alveoli merge, the number of alveoli diminishes, leading to the increased space for air trapping. Destruction of alveolar walls causes collapse of small airways on exhalation and disruption of the pulmonary capillary beds. These changes result in VQ abnormalities. Blood is further shunted away from destroyed areas to maintain a constant VQ ratio, unlike that is seen in the chronic bronchitis. Hypercapnia and respiratory acidosis are usually uncommon in the emphysema because the VQ imbalance is compensated for by an increased respiratory rate. So what are the differences in the physical findings between the chronic bronchitis and emphysema? So predominant chronic bronchitis typically has an insidious onset after the age of 45, whereas in case of emphysema it occurs after the age of 55. Talking about the cough pattern, a chronic productive cough is the hallmark of the chronic bronchitis, and it occurs first in winter and then progresses to year-round and is usually worse in the morning. Smoking cessation can help lessen the productive cough. Now talking about the cough pattern in the emphysema, it is more chronic but less productive than in chronic bronchitis. Exertional dyspnea is the most common presenting symptom and is progressive in case of bronchitis, and however the severity of the symptom may not reflect the severity of the disease. Exertional dyspnea is progressive, constant, severe, more characteristic of emphysema than chronic bronchitis. The other common findings of chronic bronchitis include the obesity, rhonchi and wheezes on auscultation, prolonged aspiration, and a normal respiratory rate. As the disease progresses, right ventricular failure is common, which presents as jugular venous distension, peripheral edema, hepatomegaly, and cardiomegaly. Because these patients tend to develop cyanosis, the term blue bloater is sometimes used to describe the patients with chronic bronchitis. The other findings in case of emphysema include weight loss, tachypnea, pursed lip breathing, prolonged expiration, axillary chest muscle use, hyperresonance on percussion, diaphragmatic exertion, and diminished breath sounds. Because the patients are able to maintain reasonably good oxygenation because of their tachypnea, the term pink puffer is sometimes used to describe the patients with emphysema. So it is very important to keep in mind that the pink puffer and the blue bloater presentations are not specific for the respective diseases. Next, we're going to talk about the complications of COPD. So first one is the pulmonary hypertension. With the decreased pulmonary vascular bed space owing to lung congestion, pulmonary arterial pressure increases. And in some cases, the pressure increases enough to cause the cor pulmonale, that is the right ventricular hypertrophy with subsequent heart failure. Next, we're talking about the acute respiratory failure. In advanced stages of COPD, the brain's respiratory center may become seriously compromised, leading to poor cerebral oxygenation and an increased partial pressure of carbon dioxide level. The hypoxemia and respiratory acidosis may ensue. If the condition progresses, respiratory failure occurs. Next complication is the infection. In chronic bronchitis, trapping of excessive mucus, air and bacteria in the tracheobronchial tree sets the stage for infection. Additionally, impairment of coughing and deep breathing, which normally cleanses the lungs, leads to destruction of respiratory cilia. Remember, once an infection sets in, the chance of reinfection can easily occur. The last complication is polycythemia. An increase in RBCs infrequently can lead to hypocoagulable states, embolism and stroke. This happens uncommonly today due to the widespread use of supplemental oxygen in the COPD patients. So that is all about the basic introduction regarding the COPD. So now let's just summarize. So in this video we have learned about what is COPD, features of COPD such as chronic bronchitis, emphysema, then pathophysiology, difference between chronic bronchitis and emphysema, then last we talked about the complications of COPD. So I hope you have clearly understood regarding COPD introduction, and if there's any doubt, comments and suggestions, please do mail us.